from Sarasota Memorial and the Deb Kavanaugh Multimedia Studio, this is HealthCast, a healthy dose of information from experts you can trust.
Hi, everybody. Welcome to HealthCast. I'm Allison Gottermeyer. Thank you so much for joining us as we learn more about new methods for detection of pancreatic cancer. Our guest today is Dr. Ken Meredith, who is the Chief of Surgical Oncology for the Brian D. Jellison Cancer Institute here at Sarasota Memorial. Dr. Meredith, thank you for joining us.
Thank you for having me.
So pancreatic cancer is often called a silent disease. Why is it so difficult to detect?
Because oftentimes it can lay in a patient's body and you have no signs or clinical symptoms that it's there. We see this quite frequently. The pancreas, you can think about it as having segments of it and 3 different delineages. And depending on where a tumor could occur in the pancreas can dictate whether or not it causes symptoms. Pancreatic head tumors or cancers, the pancreatic head actually has a bile duct that drains bile from the liver, and it can block that bile duct, and you hear about patients turning yellow or what we call jaundice. Sometimes you can get symptoms from that, but oftentimes even in those situations, it has already spread to lymph nodes. When it's in the body or tail of the pancreas, there's really nothing for it to block, so the tumor can continue to grow. And by the time you develop symptoms like pain, specifically in the left side, or pain that's in the central radiating to your back, usually it's a more advanced tumor, and oftentimes those are very difficult to treat or untreatable at all.
What's one misconception about pancreatic cancer that you wish more people understood?
I wish people would, and I give this out of personal data for my patients. Oftentimes patients will come in and they will be diagnosed with a pancreatic cancer that's curable. And yes, I use that term curable, and I hope everyone hears that, because oftentimes patients will come in, they'll be online, they'll be reading, it's like, well, it doesn't matter, I'm gonna die of this anyway. There's no cure for it, there's no treatment, and that's just not true at all. The treatment of pancreatic cancer has gotten so much better. Now, it's important that also patients realize that the treatments for pancreatic cancer involve surgery. Chemotherapy, radiation, even immunotherapy, those things are not going to cure pancreatic cancer. Surgery is still the utmost important in treatment for pancreatic cancer, and patients need to realize that even our techniques for surgery have gotten so much better. So now oftentimes we don't have to split the patient open. We can do minimally invasive and robotics, and not all patients are candidates for that, but you never know until you see a surgeon that's qualified to do it.
And I didn't realize that you don't always necessarily have to remove the whole pancreas depending on the cancer.
Not at all. As a matter of fact, the majority of times we can save the pancreas. If you do a pancreatic head resection, you're only taking out actually about 1/3 of the pancreas. If it's in the tail of the pancreas, it's about 1/3. Now, when it gets in centrally located into the body, neck, then we do have to take out sometimes more of the pancreas, but most of the time, as long as it's not multifocal, meaning it's spread throughout the pancreas, then we can save a big portion of the pancreas.
Why is early detection so important?
Early detection is important because, unfortunately, the treatments for pancreatic cancer are intense. The chemotherapy is intense. The types of surgery that you have to have are long recoveries. And so if we can screen patients before they need a lot of these treatments, we can save the patients from getting particularly chemotherapy and radiation. Now, oftentimes with pancreatic cancer or patients that have high-risk lesions that are precancerous that occur in the pancreas, we can potentially cure a patient for pancreatic cancer before they ever get it. And that's why I need patients to really that have or in that situation where they're a high-risk patient, and we can talk about that, but I need patients to hear that you can potentially have interventions that treat this before you develop cancer.
So that brings us to a new diagnostic procedure being done at Sarasota Memorial called LymphU. What is LINFU?
LINFU basically is an ultrasound. That's all it is. Just like the ultrasound we use in diagnostic, it's an ultrasound. We can talk a little bit about that, but what it is it stimulates the pancreas. And it's harmless. It stimulates the pancreas to release cells. And why that's important is because the reason that some of our technologies are limited is because we're unable to get an adequate sampling. But if we can get enough sheets of cells to then stain those for atypia or even tumor, then we can diagnose it at much earlier stages, which makes the treatment algorithm so much better.
So how does this differ from those other ultrasound technologies?
Well, let's compare it to imaging, ultrasound needed for imaging. Those ultrasounds are high frequency image. All an ultrasound is it's a wave, and it's a frequency of the wave that's then sent to the human body, and then it's reflected back, and it gives you echoes, and they translate those echoes into imaging. Now, how does that compare to LINFU? LINFU is a lower frequency, and it's not meant to really have a higher frequency to where it's causing any image reflection, but it's more of a lower frequency so that we can stimulate the pancreas, not in a harmful way, stimulate it just enough so that we can get it to release. Like you can think of it as just a little bit of a jolt, so that the cells in the pancreatic duct are released.
Prior to LINFU, what options were available for patients to detect pancreatic cancer?
Well, not any.
Wow.
Honestly, I mean, if you're a high-risk patient, then we could do a CAT scan. But a CAT scan is only so sensitive and will only show when there's a detectable lesion. So if you've got a mass or a premalignant cyst in your pancreas, we can see that on an imaging. But if you're in that stage of progression where we call it PAN-IN or pancreatic intraepithelial neoplasia, when you have that, it's a spectrum. And the lower end of the spectrum is low risk. The higher end of the spectrum is high risk and likely going to develop a cancer. We didn't have any way of detecting that progression because we had no ways to really sample the cells without cannulating or sticking a catheter within the pancreas duct itself and trying to get cells that way. But that's a very invasive and increases the risk that you're going to get inflammation of the pancreas or pancreatitis. So really, this is the only thing out there right now for screening for pancreatic cancer. The other important thing if you want to accustom this to, we have screening technologies for other malignancies. We have a Pap smear. So Pap smear is a little bit different than the LINFU because Pap smear is basically just a procedure you can do in the office. The LINFU is not a procedure you can do in the office.
How early can LINFU detect abnormalities compared to current methods that you mentioned that were, once it's already a true tumor?
Well, you can get it at that progression, right? So you can get it at that stage of PAN-IN1, PAN-IN2, PAN-IN3 or malignant. So we can detect it along the full spectrum. And, it's important to note that when you get those results and you have a discernible lesion on a scan, it impacts your clinical decision making.
What does LINFU look like for a patient? Because you just mentioned that it is not done in the office.
Yeah, this is unfortunately not. Now, it's not as invasive as my description of them cannulating the pancreatic duct and inserting fluid and contrast so we can image the duct. It's a little bit different. So first part of it is you come in, the patient sits on a table, you can listen to music, you can do whatever that keeps you comfortable, but you're awake, you're interacting, you're talking, and there's an apparatus that's put right at the location of the pancreas, and that's where the ultrasound waves go, and that's where we're stimulating the pancreas. And then once we're done, with that portion takes about 15 to 30 minutes, sometimes up to 45 minutes, just depending, on the setup, etc. Then you get a little twilight medicine, and then you get what's called an endoscopy. All an endoscopy is a tube, and you're asleep for it, so it goes down your throat, and then we park that tube that has a suction apparatus just distal to where the fluid comes out of the pancreatic ducts. We don't even have to enter the duct at all, and all we have to do is collect that fluid as it comes out.
How long does this take, and what is recovery like? Is it outpatient?
It's outpatient. You can go home the same day.
Okay.
And it takes usually, you have to factor in, the lymph, actual time for the lymph and the time for the scope. The time to collect the cells is very short, on the order of about 5 to 10 minutes. The time for lymph itself, like I said, it's about 15, 20 minutes. A little bit longer, just depending on the setup, etc. But doesn't take long, and then you go home the same day.
So earlier you had mentioned the high-risk population, and I want to talk about that. Who should be thinking about pancreatic cancer screening?
So I think if you have a known genetic mutation for pancreatic cancer, most patients are that may not realize that BRCA, it does predispose you for pancreatic cancer. The other is the unknown genetic mutations that's beyond our medical capabilities to detect right now. And we know that there is a genetic component when multiple members of a family have pancreatic cancer. So if you have a first-degree relative that has pancreatic cancer, if you have a known BRCA mutation that has pancreatic cancer, if you have a precancerous lesion in the pancreas, we call those IPMN or intrapapillary mucus neoplasms, or MCN, which is mucus cystic neoplasms. Those lesions are precancerous. Now, IPMNs, there's two varieties, those that communicate with the main duct and those communicate with little side branches. This may not be effective for MCNs because those don't communicate with the pancreatic duct. Therefore, stimulating the duct to get cells is not really going to give us the information we need to help, but certainly IPMN and precancerous lesions.
Now, the Kolchowski Research and Education Institute here at Sarasota Memorial is involved in a registry study involving this LINFU. Can you talk about what you're looking for in that registry study?
Yeah, we're trying to collect this data, or I shouldn't say trying, we are collecting this data prospectively. This gives us a lot of information because prospective means we follow over time and we keep track of the patients as we follow them. So we can take someone with genetic mutations versus some patients that have family history. And then we can do the LINFU on them, and then we can repeat the LINFU over time. And then we can see when it may change from being a benign to malignant, and then, or benign to along that transformative process to where it's PANION 1, 2, 3, to then, does that correlate with the CAT scan? So we can use that data, and then hopefully with this data, we can say, at this month with this mutation or with this family history, we need to get a scan and we need to start scanning. So we can save patients from getting unnecessary radiation from multiple scans throughout their life, knowing that when someone doesn't have a lesion on their pancreas, it's not going to help us anyway. So we can save the patient, save healthcare costs, but we can also potentially predict at what level it may change. And then we can follow that over time, and then we can also use that to predict how often we should be doing it, or if the patient needs surgery or doesn't need surgery. Are some lesions or some histological subtypes never going to progress? Even though they may have a PANION 1, maybe they're going to be stable for years and never progress. So there's so much exciting research that we can do with this and collecting this data. It's only going to help our future patients.
And it's important to note that the registry study is very different from other types of clinical research. LINFU is FDA approved.
Yes, it
correct?
is.
So
Absolutely.
they're not, some people are nervous about trying new procedures or new things. It's not the LINFU that's being studied at this point. it's how patients do, correctly?
That's correct. Yep.
Okay. So how can patients find out if they qualify for this type of screening and for the registry study at that matter?
Yeah, I think the easiest way is you can contact us at SMH. But in general, if you have a family member that has pancreatic cancer, then you should strongly, particularly if it's a first-degree relative, you should strongly consider getting screened. Or if you have, BRCA positive or a genetic mutation associated with pancreatic cancer, you certainly would qualify for this study. You can contact us. You can contact my office. You can contact the research department.
Right.
So there's multiple ways that you can even ask your primary care doctor. And most of them, I can't tell you how many times I get called, can you tell us about your study, from primary care doctors.
That's great to know. So what still needs to happen before LinFu becomes standard of care everywhere?
Data.
Okay.
We have to collect the data over time. I think we will probably see a paradigm shift in the future. We've had great experience with this, which certainly has changed our clinical decision making. So I think the more data we collect, that's the only way that we're going to be able to change the standard of care.
Now, using LinFu thus far, have you detected cancers or
Yeah.
had to perform surgery on patients?
We have.
Or?
Actually, it's changed our clinical decision making. And in my world of surgical oncology, I see it both ways. I see the patients that come in that have a mass and maybe don't have a diagnosis and they don't want surgery. And then I've seen patients come in that have a small cyst, and international cyst guideline says we should watch that. We don't have to operate, but the patient wants surgery. So on both, two different scenarios completely, but both very relevant, because at the end of the day, as a provider, we have to take in the patient's wishes. So, but our job is also to steer them in the right decision based on evidence-based medicine. And so what we've seen patients come in that, I don't really want an operation, but we also don't want to miss a cancer. So we did the LinFu, changed our decision making, did an operation, and then it ended up being multiple times have been pre-malignant and then also malignant. Other side, a patient wanted surgery and their cyst didn't reach international. There's a guideline that we follow, for evidence-based medicine on what to do with these precancerous cysts. Didn't reach criteria for surgery, but the patient came in and wanted surgery. Even though I do minimally invasive robotic surgery and the downtime is much less, our responsibility to the patient is also to say sometimes we don't have to operate, and it gives them peace of mind. So we did the LinFu and it was negative, and we're like, oh, okay. So now, and then we follow those patients and we follow both the LinFu and the imaging.
How often are patients going to be having LinFu, or is it recommended that they have the LinFu whether they're a part of this registry study or not?
I would recommend that they have it whether they're part of the registry study or not, particularly if they're high risk, number one. Number two, how often? It's a great question. We're currently recommending, we're following the pancreatic cyst guidelines, even if they don't have a precancerous lesion, we should at least do it once a year and collect that data prospectively.
What excites you the most about the future of non-invasive cancer screening?
Well, not just for LinFu, but for other malignancies and screening. As our technology gets better, this is just going to be the first of a hurdle that we're going to be able to offer more things to our patients. And at the end of the day, in the world of cancer, almost everyone has been impacted in some way or another, a family member, a friend that's had cancer. And the more tools that we have to screen patients, and more importantly, to diagnose them earlier. Across the board, the earlier detection, the earlier the diagnosis, the longer the survival. So our patients will live longer if we can diagnose it earlier.
Thank you so much for joining us, Dr. Meredith.
Thank you for having me.
And if you liked this episode of HealthCasts, please like and comment, and visit smh.com/podcast to listen to more experts like Dr. Meredith talking about the health issues which matter most to you. As always, we encourage everyone in our community to visit smh.com to get the latest from Sarasota Memorial. Have a great day.